Well, just a quick question from Mr. Pearce. You operated on me 7 years ago, and I'm not right, but I'm better. But I was wondering if you had any idea how comes it completely cured my hay fever.
Okay, interesting.
Clearly, I'm taking the credit. No idea whatsoever. No idea whatsoever. Yeah, hi, David. One of those pictures was you, actually.
For Mr. Pearce, with a pancreatic net, primary removed by a Whipple's,
Yeah.
and then metastatic disease in the liver, that's been resected, 75% taken out.
Music to my ears already, this.
6 months later, 2 clear scans.
Yeah.
Where you're talking about the combined treatments, would you continue treating from that point there, maybe with lutetium or something like that, if there's a clear scan?
Yeah, I think if you've got clear scans, then there's an argument for staying on a somatostatin analogue for its anti-proliferative action. But I don't think that there are many people who would treat more aggressively at the moment, because if you've not got signs of active disease, then there's nothing for them to act on. But there no doubt will be other small volume dots somewhere around, so you need close surveillance, and as and when something crops up, then look at other treatments. As you've already had a Whipple's, then some of the liver-targeted therapies, such as ablation and ordinary types of embolization, are relatively contraindicated, i.e. you shouldn't have them, because there's a risk of getting liver abscess if you've had a Whipple's and you then have those treatments, because you can get bacteria from the replumbed bile duct into the dead tumours. So if you get liver-only recurrence, I would have a low threshold for thinking of Certex, but that would depend on how much disease there was in there. If you've only got tiny bits of disease, then it might still be worth thinking about further surgery, because Certex works best if the disease isn't tiny, if that makes sense.
So if you have clear scans, then leave be until you see some active...
Yeah, wait for mischief.
Okay.
I'm afraid there'll probably be some, but there might not. You never know.
It's great news, thank you.
So we can give Neil a quick break. One for the dietitian, I think. Tara, please. You recommend, this is a question that's been handed in, you recommend vitamin supplementation for at least some people with NETs, but individual vitamin pills, for example, B3 and D, can be quite expensive. Multivitamins from supermarkets are much cheaper, but are they any good?
I guess it depends what kind of net we're talking about. I talked about vitamin B3 and niacin, or a vitamin B compound or complex for people that produce too much serotonin and they have carcinoid syndrome. If you do have carcinoid syndrome, obviously your medical team will prescribe that, so you don't need to buy it from anywhere, which obviously reduces costs. And if you choose to actually go for a vitamin and iron supplement, like an A to Z vitamin and mineral supplement would be best. Also, just be careful around chemotherapy and radiotherapy, what I was talking about earlier. There's a good for and against taking the supplements. So it's really a individual choice whether you choose to have them during chemotherapy or radiotherapy.
Thanks very much indeed, Tara. One from the floor.
Just a quick question for Lisa. Is there any evidence that travel immunisations can have a negative impact and create carcinoid symptoms?
Liz has actually left,
right, well,
but Philippa's going to take questions.
Thank
so
you.
Philippa, can I pass that one on?
Yeah, there's no evidence out there really to say that, and obviously you would generally recommend having them, because obviously to protect you when you do travel. So.
Just while we're waiting for the mic to come down, we've got a question over here. One question that's been passed in. What advice would you give for patients suffering from lactose intolerance? That's from Brian. Thanks, Tara.
If you do have proven lactose intolerance, so you've actually gone through the test with your medical team, the only way to manage that is through a lactose-free diet.
Hello. If you've had yttrium treatment and the tumours are largely inactive, and this is for Mr. Pierce, at the moment, would that be something that you could still surgically look at, even though they're inactive, or would you be inclined to leave them alone?
If you're relatively fit and the disease is resectable, whether it's early or advanced, I would always resect whilst you can, because even if you've had a response to yttrium, then that's great, but it does very much depend on the distribution of your disease. So without seeing all of your scans and knowing which other bits of you had mischief and which blood vessels are involved, because there are some things that we cannot do at all, and there's sometimes in some patterns of disease where we would we would always back off. But all things being equal, if your disease is confined within the abdomen and if it's technically removable with acceptable levels of risk, and there was a lengthy discussion, etc., then I'd be happy to do it.
Another one from the floor, but before that, if there's a question while we get the mic over, there's another question to come. Can I just, I'll run one while you're just getting that mic over. A question from the floor we've already had. Managing side effects. How should people with NETs manage other illnesses, especially diarrhea, vomiting, stomach pain? If you suddenly get an increase in diarrhea or pain or vomiting, how do you know if it's just the NET playing up or if you've got a bug? What medicines can you take and what ones should you avoid? Philip? This is Philippa, thanks.
Yeah, very good question. And this does come up quite a lot, sort of in day-to-day for patients. And I think it's important when it happens is you call your unit, because you can just talk through a lot of what the pattern is, when the increase happened, what makes the symptoms worse, what makes it better, associated symptoms. And that can really help to see if it looks like it potentially is to do with your neuroendocrine, or, to be honest, more commonly, it's an infection or a bug that you've maybe picked up. Because we do have a lot where people are concerned, obviously your mind is always going to go to neuroendocrine first. But often, as I say, it will be that, infections going around this time of year, that sort of thing. But there are tests that can be done, stool specimens, things like that. But generally it's about the pattern, what's happened, what's helped, what hasn't helped, what makes it worse, can help clue in about what's the cause.
Yeah, totally agree.
Thank you. Excuse me, I'm quite new to this. My wife was diagnosed about 3 months ago with widespread metastatic liver disease, unknown primary. That's after CT scans and all that. Last month she was given an ultrasound scan which showed up the mass in her liver. Again, no primary. I'm basically asking if there's anything else that can be done, or you would recommend to try and find and locate that primary, because I understand that it can be beneficial to have it removed. And secondly, could the primary be in the liver? And if so, is there any way of finding that out?
There's many different potential primary sites. So has she had a biopsy?
She has had a biopsy of the liver, yes. Okay,
sometimes the biopsy will give a clue as to the potential site. Does she have any syndromal symptoms? Yep.
Yes, carcinoid syndrome. Yes.
Classic carcinoid syndrome. There's a good chance, but not a guarantee by any means, that this will be somewhere in the small intestine or the mid-gut. With the majority of patients with a secretory carcinoid syndrome, it arises there. So I'm assuming that she's been managed in one of the big neuroendocrine centres, or...
She's due to go to the Royal Free next week.
That sounds like a very good plan. There's a number of things that can be done. You can do targeted PET scanning sometimes, that will help. If you're looking for a mid-gut primary, then sometimes capsule endoscopy, which is swallowing a mini camera that goes through your intestine, taking pictures as it goes, because sometimes the primary can be very tiny. Sometimes non-specialist centres will miss something on conventional radiology that when it's looked at by a team that are specialist in neuroendocrine disease, they'll say, yeah, we can see it here. And another option is laparoscopy, which is putting a telescope into the abdomen, blowing it up with gas, and then walking your way through the intestine to try and find where the primary is. So there are a number of options. There are other tests too, sometimes just repeating the CT with a specific set of sequencing so that you're looking, because these have often got very rich arterial blood supply, so if you time the sequences of the scan for the arterial phase, sometimes you can see little blushes of tumour lighting up that are missed on a conventionally timed scan. So sometimes just repeating the CT can be enough. Okay.
Thank you. Quick question as well from Colin. Is the stomach lining tablet taken for lifetime? It's a tablet. Staff reference is the stomach lining tablet taken for lifetime?
It depends. If you've had it after a specific operation, like a Whipple's, then a major pancreatic surgery, then yes, it will be for life. Otherwise, I think that's a question that can only be answered by the person who put you on it, because there are a number of different indications for why you might be on a stomach lining tablet. Okay.
Question from the floor? Just down here. Take this. It's all right.
Mr. Pierce was saying that it's difficult to operate on the liver if you have lots of small tumours. Is it ever possible to have a liver transplant in that situation?
Steve Jobs had a liver transplant for neuroendocrine disease, and so yes, transplant isn't out of the question, but it is not always the best option, because it does limit significantly further treatments that you can have. So even if you've got small volume disease, sometimes there are operations or sequences of treatments such as embolization or Certex that can reduce substantially the volume of your disease and make a difference to your long-term outlook. So small volume disease isn't a complete contraindication to any treatment. It just is an extra factor weighing against surgery giving you a stunning result. And if you've got some big lumps in your liver and some medium-sized lumps in your liver and a few little dots, then the sort of treatment that we would look at would be possibly surgery to remove some big lumps. We could deal with medium-sized lumps with embolic treatment, and then leave the little ones to their own devices for a while. And if they get bigger, then look at further embolization or look at Certex. But you could also be looking at systemic treatments first up. So it depends what your proliferation index is, what your primary site is. If your primary was in the pancreas or your proliferation index is over 5%, then systemic treatment might well be the best way to go with the chemo options, your everolimus and so on. But going back to the transplant question, it's really very rare in the UK to get a transplant for neuroendocrine disease. It would have to be very clear that it was liver-only deposits. There are some very, very strict transplant criteria in the UK with regard to age and tumour spread and so on, because there aren't that many spare livers knocking around. Seatbelts for you.
Right. So you can all fight over who's going to answer the next one that I've got that was brought up. What would you recommend to reduce or manage flatulence for people with abdominal nets? Probably you, Tara, I think. Thank you.
My favourite subject. that really revolves around fermentable carbohydrates and fibres. In my talk, I was speaking about insoluble fibre, and one way to decrease diarrhoea and associated flatulence sometimes is to reduce the insoluble fibre in your diet, and at the same time you can increase the soluble, the pectins and the gums type of fibre in your diet. That's probably what you try first, as long as you've ruled out any kind of drug causes. And as I said, the final kind of trial that you would do is a low FODMAP diet, the fermentable carbohydrates. That is a very, very restrictive diet, but we are doing some research into that, the Royal Free this year. So, you know, that's something that you can trial, but it has to be under strict supervision of a dietitian.
It's just gone past 4. Another opportunity to say a huge thank you to our speakers today. Tara, Liz, who's not here, and Neil, thank you so much, and Philippa for joining our panel. As you go, I look forward to seeing some of you and having a chat with you, but thank you, and thanks the crew, thanks everybody, and particularly thanks for Kathy Bouvier for huge amount of effort to pull this all together, and Maya as well. Thank you, and goodbye.